Aloha. Welcome to Mental Health America of Hawaii's Brown Bag Seminar on mental wellness of seniors and caregivers. I'm Maria Grams, the Executive Director. A few housekeeping notes. The bathrooms are turn left and then sharp left again, and you'll see a ramp. Today's format is going to be that we've asked each presenter to give a short presentation, and then I'll ask them a few questions of things that I'm dying to know, and then we'll open up to you in the audience to ask questions. And please note there's an evaluation form on your seat, and it's really important to us that you fill it out so we know what you thought of this presentation and if you have suggestions for additional presentations. A quick word about Mental Health America of Hawaii. We've been here for 70 years, and our purpose is to promote mental wellness, to prevent mental illness, to reduce the stigma of mental illness, and to improve the care and services for people with mental health challenges. We picked today's topic for several reasons. First, Hawaii has one of the fastest growing aging populations in the country. Second, baby boomers hit 66 this year. I'm one of them. That means that some of us are caregivers of aging parents, and it means that all of us are moving towards needing care ourselves. Three, there's a lot of medical attention paid to seniors' physical health, but there's hardly any recognition of their mental health. For example, did you know that males age 85 have the highest suicide rate in Hawaii of any age group? And when it comes to caregivers, they're often simply invisible, and no one's watching out for their mental health. The fact is, there is no health without mental health. So let me introduce the panelists. Our first panelist to my right is Dr. Rita Bell Fernandez. She is Clinical Assistant Professor of Geriatric Medicine at the UH School of Medicine, and she is Staff Geriatrician at Kukua Kalihi Valley Clinic and at Kalihi Palama Health Center. She's a medical columnist.
Rita Bell.
She's a medical columnist for Hawaii's only senior magazine, Generations, and she serves on the doctors' work group for the State Task Force on Alzheimer's disease and related dementia. Next to her is Dr. Tom Hardings. He is Director of Neuropsychology at the Hawaii Pacific Neuroscience Center at Castle Hospital. He is a forensic neuropsychologist, a brain rehabilitation specialist, founder and CEO of Be Dementia Free, and he was awarded the Outstanding Mental Health Leader by us, Mental Health America, at our Mahalo Awards luncheon in May. Next to him is Gary Powell. He is Executive Director of the Caregiver Foundation, a Hawaii-based nonprofit agency serving the practical and emotional needs of caregivers and individuals needing care. During his career, he has been, among other things, an author, theater director, school manager, counselor, teacher. And throughout all of those, he has been a caregiver. And finally, we have Sarah Tomkison. She is Caregiver Support Coordinator for the VA's Pacific Islands Healthcare System. Since 1991, she has been a social worker with veterans and their family caregivers in inpatient psychiatry, in a community living center, and as a foster home coordinator. So I'd like to welcome Dr. Fernandez to the podium.
We have so many experts in the room. I feel like I'm preaching to the choir, so welcome. It's nice to see many familiar faces and ohana in the room. I wanted to start by discussing mental health in seniors. One of the commonest problems facing us is depression in seniors. The percentage is really high, about 15 to 20% of seniors more than the age of 65 are depressed. That translates to about 7 million. And however, a lot of it is greatly under-recognized. And we all share the blame, and why is it under-recognized? A lot of seniors think this is normal aging. I'm just getting old, or, my friends died, or I'm retired, there's nothing more left for me to do. On the families end, they too may think that, oh, the seniors are getting older, or he's not depressed, because one of the things you may ask a senior, are you depressed, or are you sad? And more than often, the answer is no. And that's why we miss it. Seniors are more likely to say they have lack of interest, or they've lost the joy in pleasurable activities or things that they used to do. That's a stronger sign and a stronger indicator for depression. Or hopelessness. Hopelessness is very strongly linked to suicide. And we just ask, are you sad or are you depressed? And that question may mislead us. A big problem with the doctors is we have no time. And I'm an internist, a geriatrician, and also a hospice and palliative medicine doctor. And one of the biggest issues we are facing today is doctors only have about 10 to 12 minutes with the patient. That's what it boils down to. And what can you do in 10 to 12 minutes? It's very hard to screen patients for depression. It's very hard to screen patients for dementia, mainly because it takes time. And I'm so happy to see people from insurances, local organizations out here in the room, because my plea to you today is we need your help. Doctors need help. We need allied staff, we need nurses, we need social workers, we need other people in the healthcare team to help us with screening for depression, screening for dementia. There are so many scales out there. There are many tools available to screen. You can use the geriatric depression scale. One of the commonest tools used is the PHQ-9 or the PHQ-2. As seniors have more chronic problems, with an increase of chronic disease, there is a higher risk for depression. For example, stroke patients are likely to be more depressed than other seniors, or persons with diabetes are more likely to be depressed. And hence, screening for these populations is so important. And that's my plea to you all today, and that's one of the chief reasons why I'm here. Another issue that is facing us, that's really going to hit us straight in the face, is dementia. Alzheimer's disease is one of the leading causes of death. It's the 6th leading cause. It has overtaken diabetes, which is the 7th leading cause of death. And it is the only leading cause of death that is increasing. Please understand that cardiovascular disease, stroke, cancer, all these are decreasing. The mortality rates are improving with better treatment, better technology. However, dementia is on the rise. And currently, it's estimated to be about 5.6 million people across the United States with Alzheimer's disease, and this is projected to hit about 16 million in 2050. So it's something we need to be aware of, what is coming our way. And the people who are going to face the brunt of all of this is the caregivers, because at the end of the day, that is the person who is taking care of the senior, whether it's your mom, your dad, your brother, your sister. It is the caregivers. And what can I say as a doctor to caregivers? I work at Kokua Kali Valley and Kali Palama. These are 2 community health centers, and we have a lot of funding. We have so many generous organizations in Hawaii. We get funds from the Hawaii Community Foundation, from Kahala Nui. We get a lot of PIN grants and grants to help people. But one of the roadblocks that I have in helping our seniors is even if we get things to the family for free, the families or the caregivers decline it. They say, no, doctor, I can manage. And that is one of the biggest challenges, is even though we have kapuna care, and even though we have, St. Francis bathing services and all these wonderful resources in the community, hospice, it's so hard to enroll a person in hospice today. And you have to tell the family or tell the caregiver, these help is coming to you free. So it is one of my biggest challenge in getting caregivers to accept the help. And that is my plea to all the caregivers in the room. If it's nice to just even take a week to try it. For example, hospice is something that is covered by medical insurance. It's not an out-of-pocket expense, but still families decline hospice, and you're getting a nurse checking on your loved one every week. You can get bathing, CNA services 3 times a week, and all this at no cost to the family. So to all the caregivers in the room, that is my plea to you to please be open to accepting help. The treatments that are out there for dementia aren't the best. We still have a long way to go as far as better drugs, hopefully a vaccine one day, but we have a long way to go. Regarding depression, there are very good medications that are out. And usually a person needs to be on a antidepressant for about 6 months to a year. It's not something like antibiotics that you take for a week and you're done. So we have to remember to refill the medicine and let the person stay on the antidepressant for at least 6 months. A big thing that helps people, whether it's dementia or depression, is socialization. And in Hawaii, we are so blessed with the Senior Citizen Center, so many programs that are out there that can keep the brain active, will help people develop new friends. The socialization reduces the risk of developing depression or dementia. And I'm a firm believer of exercise, health maintenance groups, senior citizen centers. They all do wonderful work in our community. Well, I will end with this, and I'll let Dr. Harding come next and speak to us on seniors and other challenges. Thank you for your attention.
Thank you, Dr. Fernandez, and now I'd like to welcome Dr. Harding.
Good morning. Can you hear me okay? Okay, neuropsychology, what is that? Well, basically I assess brain function. If you've had a stroke or a head injury, you would come to see me and I would find out what parts of your brain you damaged and what part's still working good. And the forensic piece, that's, I don't work with dead bodies for those of you that watch too much TV. Forensic work, I also go to court quite often and I talk to the judge and the legal team about capacity. Does someone have the capacity to make a decision, financial or medical? Do they have the fitness to proceed with the trial? That's the forensic piece that I do. And so I deal a lot with brain function, and people ask me, you know, I'm having memory slippage. Am I going to get dementia? So what I want to do is frame this conversation about, you know, what's normal brain function, what's dementia. And the easiest way to do that is with some slides I have here. And for those of you that are taking lots of notes trying to keep up, I would want you not to do that. If you just go to my website, a lot of these slides that I'm going to show you are up there. There's lots of good information. You can go up there and read and look through. And if you forget what I said today, you can just go right up there and look at it there. So that's the only thing you need to write down is bedementiafree.com. Okay, so let's look at average memory decline. So for those of you that are seriously concerned about this, am I going to be demented? Because I see patients on a regular basis. How many people in here have had a senior moment in their life? Okay, look at that, all right. So, and for those of you that aren't sure what senior moments are, it's you're on the couch, it's something pops in your head, I'm gonna go do this, you go into the room, you get in there, you have no clue why you're in that room. That's a senior moment. And you don't have to be a senior to have one of those moments. So let's take a look at average memory function here. If you can see here, there's 2 lines. This black line here, this is verbal memory, okay? Your ability to remember a phone number, or someone's telling you their phone number or their name, okay, that's your ability to recall that information. And then we also have visual spatial memory, and that's your ability to remember where you parked your car at the mall. Okay, yeah. So if you've ever forgot where you parked your car, you're not alone. I can tell by the the laughter in here. So visual spatial memory, that's the right side of your brain, okay? So we'll assess that. And then verbal memories over here on the left side. So we check both sides. And if you look at this in your, and don't worry about the Z-scores, that's not important. What's important to understand is this decline here. Now this is average function. This is not dementia, okay? It's okay to have a senior moment when you're in your 70s and 80s. Look how far down you've come. You've come down 1 standard deviation. Okay? Yeah, you're not what you used to be, but you're not demented, okay? It's okay to have a senior moment. I want you to breathe a little bit, okay? All right, so now that's not dementia. You have to go a little further than that. I'll show you what that looks like. Okay, this slide shows you this nice yellow line right here. This is healthy brain function, and as you can see over the course of life, 50, 60, 70, 80, even a healthy brain is going to lose some brain power. Okay, it's called age-associated memory decline. It just happens. If you're in your 70s and 80s, you're having a senior moment, and that's all you have, you're doing great. Now, if you're in your 60s right here and you're starting to have some senior moments, and then every now and then is good. If they're starting to come closer together, like it's happening a lot, you need to come see me. I'll just leave it at that. But as you can, that last photo you saw, that decline is only to right here. You have to go much further down here into the early stages and medium stages and later stages of dementia. So it's okay if you're having a senior moment. That doesn't mean you're going to have dementia, okay? What I'm going to do next is I'm going to straighten this line out here. I'm going to show you what the brain function continuum looks like. So over here on the left, we have what's called normal brain function. And over here, we have dementia. And there's a few stops along the way here. You know, I have people come and see me, they go, Doc, you know, I'm having memory problems. And first thing that pops in my mind is that's good. They're aware they're having memory problems, because most people who are demented, they have no clue they're having memory problems. So if you're worried, that's good. So as you come down on that 1 standard deviation that you saw, that's just for average American that's eating average food and living an average life with no exercise, no mental stimulation, you're going to lose about 1 standard deviation. That's going to put you right here at what we call subjective cognitive impairment. That's another word for senior moments. That's about where you're at. So you're not anywhere close, okay? It's all right. If you come a little further down, now there's a thing here called mild cognitive impairment, or MCI. Now that is something to worry about. That's a diagnosable condition. And the way you can tell if you've got SCI or MCI, some of the things that you can look for is, or your friends and your associates may be able to look for in you, is go to a movie and you have a hard time following the plot in that movie. You know, you may have a little bit more slippage than you should have. If you read a book and you have to go back to the top of the page to look at what you just read, that's a sign that you've got a little bit more slippage than you should have. If you're still working and your coworkers are noticing that, you know, he's not performing like he should, I'm having to pick up after him and cover him a lot more than I used to have to. Coworkers tend to notice these slight changes before we do. It's kind of like, you know, as you age and you lose some memory, it's kind of like trying to watch yourself lose weight. You just can't really, you can't see yourself lose weight. But your friends who haven't seen you for a month, they can look at you a month later and go, wow, you've lost some weight. So they're a little bit more acclimated to these things than we are. Okay, so that's MCI. And if you go a little further down, here are the beginning stages of dementia. This is 2 standard deviations, and that's when we start talking about brain impairment, early stage dementia. And then there's moderate stages, and then there's the final stages of dementia. And this word dementia, this is something I have to answer every day that I see patients. So let me just do it now. There's lots of ways to become demented right here, okay? It's not just Alzheimer's. So I talk about the dementia pie. This is the easiest way to think about this. So if you take a look at this, think of a piece of a pie and you just cut it up in different pieces. Let me make that larger. There we go. So Alzheimer's disease that most people have heard of, that's the biggest piece of pie. Now, this pie changes regionally, okay? It's not like this everywhere. This is more, I'd say, mainland, northeast, where you've got about 62% Alzheimer's cases. And then there's vascular dementia. Now, that's when you have like a stroke, You ever had that? You ever heard a doctor tell you had a TIA, a transient ischemic attack? There's some vascular changes going on in your brain. Those are vascular changes, okay? And then there's something called mixed Alzheimer's and vascular dementia. I'd like to go right back here to vascular dementia. They've done some research here in Hawaii, and we found that about anywhere from 20 to 30% of the cases here in Hawaii are vascular. So we've got quite a bit of that, okay? And you can also, by the way, alcohol-related dementia, if you can pickle your brain, you know, if you drink quite a bit. I see about 2 or 3 of those a month. Someone's just had chronic use of alcohol. By the way, 1 drink for women is okay, 2 for men is okay. Anything over that is, you know, is a problem. So if you're having more than that, just keep in mind that you're doing more harm than good. Okay, so dementia and Alzheimer's. Alzheimer's is a type of dementia. There's a quiz at the end of this. Okay. So that's dementia. Now, I get asked quite a bit. I've got 5 more minutes. Let me just see if I've got time. You know, quite often I'm asked, well, what are my odds of becoming demented? Well, in your 80s, if you add all those different pieces of the pie up, you've got about a 50-50 chance of some form of dementia getting you if you don't take precautions and take care of your brain. And if I have time, I want to show this right here. Okay, let's talk about the impact of dementia on health in Hawaii and healthcare costs, because who's going to pay for all this, yeah? So this started way back in the 40s. Remember when World War II ended and all the soldiers came home? They started having babies. My dad had 8 with my mom. So, of course, we had this doubling of the number of births there. And so we've got this swell of baby boomers, yeah? South Carolina did an Alzheimer's disease registry. I'm going to go through this real quick, and this is how they put it together. They have a bunch of clinics and hospitals information, and they did this over a course of years, and they got the registry. And what they looked at was not just Alzheimer's disease, but they included vascular dementia, mixed dementia, and all these other ones. These are codes. And they ran that through their system, and they discovered that 85 plus makes up 36%, 75-84 is 35%, and 65 to 74, now that's the first boomers right there, 19%. That makes up 90% of the cases, okay? So getting old is a risk factor. What's it gonna cost? Okay, take a look at this right here. This big blue bar right here, these are people who have dementia, and this is hospital stays per 1,000 people. So if you have dementia, you have a lot of problems, and you go to the hospital, and it costs us a lot of money. If you're healthy, you're way down here, okay? So national costs, we're looking at over $1 trillion by 2050. Now, how much of that is going to be Hawaii's, right? $1 trillion, can you imagine? So if you look at Medicare and Medicaid costs, people with dementia and people without, Medicare is going to go up 3 times. Medicaid, which is state money that we get from the feds, is going to go up 600%. Anybody think we've got 600% increase in Medicaid? Hawaii's population, if you look at this right here, we've got, these were projections they made. In 2010, we were supposed to have 1.3 million. They did the 2010 census. They found out we have 1.38 million. That's up here at 2015. So we're running ahead of projections in terms of how many people are living in Hawaii. And who's got the oldest people? Well, let's see here. The national average is 12.8% over 65 years of age. Florida's got 17. Hawaii's got 14.5. We've got the second, per capita, the second oldest population in Hawaii. Yeah. So we've got our share of seniors here. Now, what's it going to cost? Real quick. This is our total budget that we had back in 2011. We had $12.5 billion. $2.5 billion we spent on health care, okay? Okay, I want to show you this again. All right, now look at that size of that wave, and let me show you some numbers. I call this what if. This is the what if game. Okay, West Virginia right now is putting together a registry, and they're saying that currently it costs $175,000 per demented patient. I've been meeting with HMSA a number of times. Their director, Bill Osteroff, says in Hawaii you can round those costs up to $200,000 a patient. Now the good news is you don't have that $200,000 in 1 year. So if you look at our 2010 census, 1.38 million times 14.5%, that was 65 and over. That gives us a couple 100,000 people, yeah? 100,000 cases times 200,000 is $20 billion. But we get to divide that, right? Average Alzheimer's patient lives about 10 years. Some live longer. I've known people live 20 years. I've known people live less. 8 is average. I'm going to round it off to 10 for easy math. You take 20 billion divided by 10 years, that's $2 billion a year. Now, when a wave comes, and if we don't prepare or do something about it, let's just say it goes to 150,000 cases times 200,000. That's $30 billion. Divide that by 10, that's $3 billion a year. And how much did we have for total healthcare budget? It was $2 billion, yeah? There's 200,000 cases, that's 40 billion, that's $4 billion a year. So clearly, we can't afford these kind of numbers when this happens. So those of you, how many caregivers do we have in here? Okay. In 5 years, I'm going to ask that question. Almost every hand is going to be up because everyone's having to take this on. It's, who can afford to go somewhere? You know, we take care of our own at home, and not many people are prepared for it. I believe that's all I've got. Yes, that's all. I'm going to stop. Yep. My time was up. Okay. Thank you.
Thank you, Dr. Harding.
Good job.
So I just have a question. How many in the audience define yourself as seniors? So does that mean that's everybody over 60? Is everybody that raised their hand over 60? Or there's some more? It's interesting how we define ourselves as seniors, because sometimes we get to be this age and we don't feel like seniors. So now I'd like to bring on our caregiving expert. Thank you.
Caregivers, interesting group of people. See if we can, is it gonna? See if we can get technology to work for us. How many are caregivers again? How many of you have ever received care? Oh, you're wrong. Unless I'm mistaken, everybody at some point in your life had somebody else bathing them, feeding them, changing their diapers. Now you get it. We've all been there. Sometimes in life, people end up needing that type of help again. But caregivers in general affect all parts of society. They're either providing care, receiving care, getting ready to provide care, or having received care themselves already. Caregivers experience just about every emotion that's known to man, and then some. Most of the emotions they kind of come and go as normal, but some of the emotions stick in our heads, and they don't go away. Don't worry about that. If it doesn't work, it's okay. Don't worry. Some of those emotions that stick cause mental health complications for us. But before I tell you what I call the the unholy trio of caregiver emotions, let me tell you a little bit about what causes them. You know, as we get older, our parents get older, and sometimes we have a conversation that kind of goes like this, like the one I had with my dad. He said, "Gary, promise me that when I'm old, you'll never put me in a care home." How many of you have had that conversation? Anybody? Well, he was real insistent. And I said, "Oh, Dad, don't worry about that. I'll take care of you." I made a promise, probably in haste, very likely out of a desire not to face the fact that he is getting older, that someday he may need care. And when the time comes that he might have to have care, I'm going to be like so many other people. We look at ourselves and we feel that we have to keep that promise. We enter into the task of caregiving with very noble and determined attitudes. Hey, there we are. Now you expect me to know how to use this thing, right? Okay, I figured it out. Thank you. We end up setting ourselves up. And once we've actually entered into that caregiving role, we begin to look at things a little bit differently. We get so busy that we push aside our family and friends in an attempt to both look good and to do good. Once we've really been getting into the work very heavily, we set ourselves up by figuring that nobody else can do the caregiving as well as we can. So we don't ask for help, we don't accept it, and very shortly we begin meeting what I call the unholy trio. We meet resentment, anger, and guilt. And if we're not very careful, these can become the predominant emotions in our lives. This trio moves in. We look at our friends who aren't caregiving, and we reflect on what has changed for us. We see the rest of the world going along its merry way. Our friends can have conversations with each other. They can spend time with their partners. Our friends can go shopping. Our friends can do so many things that our caregiving tasks prevent us from doing. Our friends can even have sex. What do we get to do? Well, we get to have conversations that very often don't make any sense, especially when dealing with dementia. We get to spend time, almost all the time, with our care receiver. Our shopping involves insure and depends. We have to bathe, clean, change, assist, feed, keep doctor's appointments, on and on and on. And we think we may have even forgotten what sex is. So we find ourselves becoming resentful. That ugly head of resentment sometimes doesn't come into the process for quite a long time. For others, it comes within a matter of days, sometimes just a few weeks. We sail into the work, we make plans, we get everything set up just right, and then discover that those plans didn't work and the things we set up just right are all wrong. The schedules that look so good on paper didn't work at all. We began to have thoughts like, I didn't sign up for this. Nobody else helps. I think I'm so tired I might die. Resentment can morph into anger. Once those feelings of resentment focus all of our energy onto the problems and the frustrations of caregiving, it starts to tick us off. We can get angry at the situation that made us be a caregiver. We get angry at everyone else in the family that doesn't even help and has the nerve to complain that we don't pay them enough attention. We get angry at our care receiver. Why didn't you plan for this? Why can't you try harder? Do more for yourself. Complain, complain, complain. You never like how I'm doing anything. And then we get angry at ourselves for not having seen this coming and getting stuck in it. How could I have been so stupid not to see? And we can fill in the blank. Anger transforms into guilt. We often end up feeling terrible about everything. We have guilty feelings about having gotten mad. We feel guilty for not taking care of our spouse and our kids. Guilty for not spending time with our close friends. Guilty for feeling resentful and angry at our care receiver. And even guilty with ourselves for not being able to take better care of ourselves. Resentment takes even the smallest problem and focuses so much attention on it that it begins to grow in our minds. That growth develops into anger, and when improperly handled, it can lead to mental health issues like depression, a host of physical problems, and even what sometimes appears to be early onset dementia. The death rate from heart attacks, suicide, accidents, and the incidence of stroke and related conditions increase among caregivers. Guilt is not resolved by trying to block resentment and is often the result of improperly expressed anger. Now, there are times when we should feel guilty. It's always appropriate when we have deliberately caused physical or emotional harm, when we've said cruel things. Guilt should lead us to change that behavior. When we've done less than proper form of care, guilt is appropriate and should be a motivator. When we have intentionally caused harm, guilt should drive us to change or to seek some form of intervention. That's appropriate guilt. But more often, we live with inappropriate guilt. Feelings such as regret and sorrow are often more suitable and allow us to experience emotions in a manner that can actually increase our humanness. Helps us to understand things better. We can regret, we can feel sad, but usually we shouldn't feel guilty. Coping with this unholy trio requires us to make some deliberate alterations in our life. Instead of feeling resentment and allowing it to start feeding on our brains, let's be honest about what we feel and don't hide the feeling. When we're frustrated and resentful that our family is not caring enough, let's find a non-combative way to express that. We may find that rather than not caring, they simply don't know what to do to help. We can manage our feelings of anger by understanding that parts of caregiving are simply never going to change. Much of our frustration and anger is the result of us trying to change aging. And if you haven't figured out already, it's a fatal condition. We're all going to age, we're all going to die. When we learn to accept that, we can accept some of the tasks of caregiving in a different way. We can learn to regret that Dad can't walk by himself instead of being frustrated and angry that he can't move faster. We can regret that Dad has the inability to keep himself dry at night and try to understand things from his perspective of embarrassment. We can learn when guilt is appropriate and when it is not. Understanding the difference between guilt that motivates us and guilt that depresses us is very, very important. So the unholy trio is not a trio that sings very well together. It's something that we need to control. Okay, where did that go? Joan Baez said that we don't get to choose how we're going to die or when. We can only decide how we're going to live. How are you going to live your caregiving life? Will you grow or will you be dominated by the unholy trio? You get to decide. We grow because we struggle, we learn, and we overcome. Thank you.
Thank you, Gary Powell. And now I'd like to welcome Sarah Tompkinson, another caregiving expert.
I guess I'm the cheerleader of the group. And actually, I'm going to try to tie in everything people had brought up, but I'm going to need my glasses because I'm not vain. I'm getting old. First of all, I want to take this moment to really applaud all of you because if you didn't know, November is National Family Caregiver Month. So I'd like to ask everybody that is a caregiver to please stand so that we can give you a round of applause. And this year, the proclamation, and this year's theme is Family Caregivers Matter. Thank you. And I think it's also National Hospice Month as well. So, you know, when I talk about being the cheerleader, I want to really tie in what everybody was saying. It's so important. But we have an opportunity, and I say we as family caregivers because I've also had the opportunity of being a secondary caregiver and primary caregiver for my mother-in-law who passed away at 102. So this is very dear. I'm very passionate about being a caregiver and just blessed that I am a social worker that works at the VA. It's really hard if you're a health professional and you're caregiving with your own family, because everybody in the family expects me to do certain things because I'm the social worker. And so I think that was the biggest challenge, is for me just to be able to tell them I'm wearing the daughter-in-law hat. And I could live with that. So I'm going to move pretty fast, and that's why I'm calling this Wellness and Family Caregiving, because I want you all to take care of yourselves and stay well, because that's important for your mental health, okay? And I think all of us would agree here on the panel, that's what we want you to do. So I found some little interesting, oh, I have to move this thing, yeah. This is some interesting statistics that I got out of 2000, and there is a caregiver website. I think also the State Executive Office on Aging is a great resource. They have a lot of demographics. But look at this compared to the United States. I was looking at the part that interested me was the last two sections on how many people are living alone, that's over 65. You know, we're not too far behind. And then households with internet access. Because I'm thinking like, wow, that's pretty cool. In fact, we're just par with the United States. And now that I have grandchildren, I have to really kind of get hep with FaceTime and all this stuff. So, you know, I just wanted to say a little bit about this slide. When we think about informal caregivers, I think that term really applies to unpaid family caregivers. And you people that were in this room that stood up, I know you're not getting compensated. So clearly, this group we're addressing, the panel, we're talking about informal caregivers that don't get paid for what you do, as opposed to paid caregivers like in the care home or from an agency. Here's some little demographics about the care recipients here in Hawaii. We also cannot overlook the fact, I know we've talked about baby boomers, but we haven't mentioned about those people that have developmental disabilities. People with mental retardation are living longer, people with other types of disabilities. So I think we're also going to be faced with that group. So I always think about adults, anybody over really 18 that, you know, we're going to be challenged with caring for. So what are the types of disabilities that we have for people? There's the sensory challenges. And, you know, when you think about hearing and vision, that's especially important, because if you don't have your glasses on, I can't really read clearly to do the presentation. Or you could even, you know, you could even fall if you're not seeing and hearing correctly. So these things are important. The physical demands for caregivers are there, like especially if you have someone that has had a stroke or amputation or other conditions, you know, just having to transfer or carry the person, et cetera. Then there's the self-care aspect. If the person needs help with more than bathing, there might be treatments that they have, like if they're insulin dependent. And of course, since we're talking about mental health, I focused on the, I don't know how to move this thing further down, but if you look at the mental challenges, I think what's meant by that is not just the dementia, but people that also have depression, anxiety, and other things. I'm going to get some water. I took an antihistamine. Thank you. So it's drying me out. But yeah, that's very significant, again, about the, you know, the people that you're giving care to. They probably are also quite depressed because of the multiple losses that they're faced with. They're probably very anxious if they've fallen at home and they're really scared to be alone. That causes worry. There's difficulty leaving home for a lot of our clients. Now, this is the cool part. I decided as a tribute to my husband that I wanted to talk about the differences between caregiving for men and women. And everything I think that I learned about caregiving has come from my husband. And one of the most critical things that he said to me was, you know, Sarah, I think it's really important when I take my mom to the doctor, nobody ever asks me, how are you doing, John? It's, how is your mom doing? So I always made it a point when I came home from work to ask my husband, how was your day, honey? How were things with your mom? Is there anything I can do? So this is a tribute to my husband, John. And he said, you got to think, Sarah, men are different than women because men think differently. And I said, really? He said, yeah. Like we don't like talk story, vala'au. We just want to fix the problem. And we've been raised in a society where we're supposed to provide for our families, we're supposed to protect our children, our wives. And so it's really hard for us as a caregiver. Someone mentioned that caregivers are invisible. Imagine for men. Men, it's even harder, I think, because it's misperceived as often something where they're weak and they don't have courage. I think men are the most courageous caregivers that I have worked with because I work with the VA too. And many of the men are caregiving for some of our veteran women. So here I've just outlined it. Men have to cope with depression, the financial hardship, and limited personal time problems like their female counterparts. Actually, some of the men, like my husband, they had to work even longer because they're worried about how they're going to pay for the care. They also neglect their own health because they are so focused on their wives or their mothers or their other siblings. And again, I mentioned, they're much more task-oriented versus talking. I don't mean to stereotype the men in the audience, so you can disagree with me later. But I think for the most part, this is what men are having to deal with. Men may seek emotional support indirectly, like for my husband, doing the guy thing was, he didn't want to talk about it. He worked in the yard. He worked on the car. And that's how he figured things out. Like he was really worried about how he was going to transport his mother in the truck. It's like a Ford 150. And I offered to drive, of course, but he wanted to do it because he promised his mom, Gary, that he would take care of her at home. And she was very fortunate that she died at home. He was able to honor that. Men are at risk for being more isolated than their female caregivers. Because again, guys don't want to talk about their feelings and emotions. So again, my husband says, you think I'm going to a support group? You're crazy. I don't like sit there without a woman. So I think that's going to be my recommendation. I have some recommendations at the end, and I really think it's important that it's good to have support groups, but they have to not just be age appropriate, they have to also be gender appropriate, okay? Men are more likely to delegate or hire an aide to assist with personal care. It was funny because my husband, we did that, but in our culture here, a lot of times in Asian culture, they don't want strangers or people in the house. So I helped to bathe, but there was a time when she had like an accident. My husband said, he pulled up his boots and he told himself, I can't let her sit in her poop. So, what was really important was he communicated with his mother. Is it okay if I take off your pants? And that would, every step of the way, so she wasn't embarrassed, and he wasn't, also, he made sure that he asked her, are these things okay with you? And, going in the shower. So women in caregiving, I'm also a strong advocate for women. I think, unfortunately, again, in our society, women have been raised to be nurturing. Think of it from small kid time. You're always caring for somebody. Like whether it's the dog or, it's your best friend at school. But what worries me is that we also have to think about women's health. Women are 6 times as likely to develop the symptoms of anxiety, depression, as compared to those people that aren't doing caregiving. 25% of women caregivers have health problems, and that's outlined further below. I think, I didn't finish that, but we're seeing actually when I talk about mortality, and maybe Dr. can certainly, Rita Bell can address this too. We're seeing more and more women, they're getting heart disease and other chronic diseases. But I think definitely men and women, your immune function is compromised. Think about it, if you're not sleeping because you're caregiving, you're not eating well, all those things are going to affect your overall health. There's the financial challenges for women especially. I know that a lot of women, they've lost wages, they've had to cut back on the hours that they're working, many have to retire early. And what worries me is because women to begin with are paid less than their male counterparts, their Social Security, they may not get a Social Security, their pension amounts are reduced. So this is going to be an economic crisis of proportion if we don't also begin to think about the impact of caregiving because you caregivers actually are the people that's really helping us keep afloat in addressing the long-term care needs of this community. And I think Dr. Harding talked about that. He gave you a nice display of how much in the millions and billions it's going to cost this whole country. So I like this little saying, when the world says gives up, hope whispers, try it one more time. So I wanted to just quickly talk about how it's important that you be able to take care of yourself. These are some of the things I do with our family caregivers. First of all, we acknowledge that you are doing the best job as a family giver, that it's okay to ask for help and to know that you're not alone. Our other panelists, Gary had mentioned that, attend caregiver trainings just like Mental Health America. There's a lot of classes and conferences. If you're comfortable, look at caregiver support. If you can't attend a support group, I understand there's social networks. I haven't tried this myself, but I think a lot of people are using this. And then lastly, think about respite care. And respite's a fancy word, it just means getting help. Take care of yourself. Build a partnership with your own doctor. Communicate your health concerns. If you're starting to have more than those aches and pains, like you notice your blood pressure is going up, you need to tell your own doctor. Take the time, eat well, stay healthy, exercise regularly, choose pleasant and nurturing activities. When I say exercise, even if it's just 15 minutes, do it like 2 or 3 times throughout the day. But you've got to just be able to, get out of the house, do something kind to yourself. Enhancing caregivers' mental health. So I mentioned again about promoting wellness, the training and education. I think I wanted to mention at the bottom, another area that I think our committee has to look at is employer-sponsored caregiver support programs. Because of the baby boomers that are having to work longer, we need to go to our companies, our corporations, several hospitals. I think HMSA, they do that. They take care of the program for employees, but really reach out, give the employee time off from work. I mean, there's got to be more flex schedules or alternative work schedules for these people. So I just wanted to talk about resources. Many of you have the green handbook. I think it's the city and county information and referral handbook. I mentioned these in particular because I love these people. Kakua, Kalihi Valley, I think they're only for the Kalihi area. But all these programs are comprehensive, so there's, social workers available, except for, I think, Kakukali is the only one that has physicians. But this is pretty much that, and I think I'm going to end there.
Thank you, Sarah Tomkison. Is that right? So thank you to our panel. You've done a wonderful job and hardly left me with any questions, but I just have a few. I was wondering if one of you could talk to me about the difference between when a senior is grieving for the death of somebody versus when it turns into depression.
You're the doctor. I can give you my opinion.
There is no magic time set after a person's death to determine whether it is normal grief or complicated grief, where depression is a part of complicated grief. However, if the person finds that they're unable to do things that they used to do, it's difficult to get out of bed, they stop going out, they're not eating, they're losing weight, and they have clinical signs of depression, that's something to go and talk with your doctor and get evaluated for possible depression. So complicated grief is usually seen in suicide deaths, when there are multiple deaths, complicated deaths. That is a higher risk for complicated grief. Mm-hmm. Gary, would you like to add anything?
What would a caregiver do if they suspect that the person they're taking care of has depression, has severe depression or complicated grief?
Well,
I guess it's on. I think it's important for the caregiver to have already established a working relationship with the care receiver's physician. And we all are familiar with HIPAA, so that's something that needs to be gotten out of the way right up front. But the caregiver needs to be able to talk to the doctor and say, I think there's a problem. And then let the physician either refer or guide the process of evaluating to try and identify what the problem might be and how to handle it.
Are you talking about depression with the caregiver or the depression with the patient?
The elderly person.
Okay.
If the caregiver begins to notice there are possible signs of depression, and I think many seniors are very reluctant to get help, and they also likely don't recognize they're depressed.
Yeah, I think Dr. Rita Bell did a great job, and I think other physical things you can look at is like if there's weight loss, significant weight loss. I mean, I guess would that be like 10, 20 pounds, doctor? You know, especially if they go regularly to see the doctor, and you'll know because the person's not wanting to eat, they're sleeping all the time. So it's not going to be too subtle, I think, over a period of time, huh, Dr. Harding? Or Rita Bell?
I was going to say the challenge is when the elderly person dies and the caregiver is depressed. Who's going to notice that? Who's going to find that out? And one of the most beautiful organizations is hospice because they visit the family 1 year. They provide bereavement support. It may be a case management agency that visits the caregiver and say, how are you doing? And that's the person who will say, I think you need to visit your doctor. So we say a big thank you to all the angels out there.
We find in our caregiver support groups that very often the caregiver will continue to attend the support group for sometimes years. We have one group where about 20% of the group are what we call graduates, and they come, part of their process is now supporting other caregivers.
You know, I read a letter to the editor of the New York Times, and it was a caregiver, and she said the best thing that happened to her is every time she brought the elderly person she was taking care of to the doctor then turned to her and said, so how are you doing as a caregiver? And, you know, gave her attention and gave her care. And I think that's what it would be great if we could convince all the doctors who are seeing seniors to do that. In terms of Alzheimer's, I know there's something called neuropsychological testing, but I don't know what that means.
Okay, so neuropsychological testing, that's basically cognitive testing, testing brain function. And it usually comes in the form of testing memory, testing planning, problem solving, reasoning, frontal lobe, executive function. So if a senior comes in and we're going to do all of that, we're also going to screen for depression because sometimes depression can appear as pseudo-dementia. This is where, you know, usually a depressed patient already has slow processing speed or slowed thoughts, and they may seem forgetful, and someone may think, oh, they're becoming demented, when really what it is a mood disorder. So we screen for that as well.
And so how long does this neuropsychological test take?
We'll usually have someone come in for a couple hours. We try to keep it short because, you know, sometimes seniors don't want to sit that long. But, you know, full batteries, back in the day when I was a grad student, we'd spend 4 hours with somebody. But insurance just prohibits that. Now they won't pay for that. So what we do now is we try to get as much done in as short amount of time as possible. So about a couple hours, if someone comes into the clinic, they're going to be asking and answering questions and doing some paper and pencil testing, no needles.
Now, I think
on November 13th, it's National Memory Screening Day, so you might want to look around and find a place near you, spend 5 or 10 minutes doing a paper and pencil test.
November 13th?
November 13th.
See if we can remember that.
If you go to my website, I have a visual memory screen up there. If you can't find a place to go to, it just shows you some pictures, and then you have to print out a piece of paper that's got the circles to fill in so you can keep up score. And then you'll see some, you know, some of the pictures will be repeated and some of them won't, and you have to be able to remember which ones you saw. So it's a visual memory screen. It's not a diagnosis, but if you don't do good on that, you should go see somebody.
Now, some people, many of us say, well, yeah, I'm getting forgetful and I'm a little scared, but why should I go bother be tested? Because if I find out I have Alzheimer's, there's nothing I can do, and I'll just get really depressed.
Okay, but maybe it's not dementia. Maybe it's due to another factor. Maybe it's mood. Maybe it's because some of the medications that you're taking, a lot of seniors take a lot of medications, and some of them can have interaction effects, and it can affect your cognition. And maybe it's just something that's fixable. It could be a thyroid disorder. So there's lots of reasons that you could be losing your memory that are reversible. So for folks who, it's kind of like I've got a sister. She pops in my head. She doesn't want to know she has cancer. She won't go and have herself tested. She just sort of. Whereas my dad, he gets himself screened, and when they found the lung cancer, they took it out quick. And so, early prevention, early diagnosis can extend and delay, some of these illnesses. So for those people who are worried and what good would it do, it could be something that could be fixed. And with correct treatment, we can delay the onset and so give you some more quality years before it really starts going downhill. Mm-hmm. And so don't just think of yourself. Think of that family member, that caregiver that has to, put up with this. So if, don't be selfish. If you think you've got a problem, have it looked at.
Mm-hmm. I think there's a lot of stigma against older people. And I think one of the ways that takes effect is that we kind of think, well, if you're older, of course you're depressed. Maybe you've lost your partner, maybe your kids aren't paying attention to you, you're sick, you're living alone, maybe you have reduced financial situations, or maybe you're in a nursing home, so of course you're depressed. So I think a lot of even medical professionals say, well, depression is a natural part of aging. And I'm wondering if you all have any comments about that.
Well, I think, for social workers, it's really important that we look and do what we call a social history. If you really try to sit down with the person to find out what their lifestyle was like, what their values are, and you really you get a picture of this person that was going to Zumba classes, for the last 5 years, they were volunteering, and then all of a sudden, as the doctors had mentioned, they lose interest in these activities. They don't want to attend, or they just can't get out of bed. So you want to make sure that it starts actually with a good biopsychosocial assessment, and I think the doctor can speak to that, the two doctors.
Thank you, Sarah. One of the depression is not part of normal aging. So to all the caregivers out there, it's not part of normal aging. However, there are certain life stresses that may occur, whether it is death of a friend, loss of a pet, whether it's a stroke, something might happen. So the DSM-4 is very generous, and they've accommodated this category, adjustment disorder with depressed mood. So it is depressed mood following some event, and that does merit treatment, and seniors do improve with antidepressants.
I've come across this very startling statistic, and that is that 20% of elderly suicides saw their doctor the same day, 40% saw them the week before, and 70% saw them the month before. And to me, that's so distressing, because it means these doctors have not been screening for depression, and they may have well had some bad medical news to give these patients, but they haven't considered the impact. And I wonder if, Dr. Fernandez, do you see that changing at all?
That distresses me extremely as well. And one of the issues is the law, the legal issues in the United States, because the pendulum has swung in the other direction between hospitalizations and psychiatric hospitals to now nobody is being hospitalized, and they want people in the community. Right. So I've been extremely frustrated when I send a senior to the emergency room who I feel is suicidal, and later to learn that the person was sent home. And I said, how did that happen? And the law is such that if someone is not going to commit suicide today,
right,
or this minute, they can be sent home. So unfortunately, we are dealing in a system that has gone the other direction. So it is very frustrating.
It is, for all age groups.
Yeah, it's imminent harm when they're doing their assessment. If they'll contract for safety, they'll let them go home. And, the ERs are full. I also work for adult mental health division. I work with severe persistent mental illness, and they're in the same boat. They're talking about suicide. We'll send them in to the ER. ER turns them out that very same day.
Yeah, I know.
Yeah. And, I'm probably the reason why some of these people commit suicide that same day, because they come see me. They come see me, and I have to give the bad news. I'm the one that's sitting down with the family, and I'm going, this is early stage dementia. Let's start talking about planning. Let's get some things in place. And, I do my best to hand them off to support and caregiver groups, and we are short on caregiver support. There's just no question about it. Quite often I give them the information to the Alzheimer's Association to see if they can start looking. Well, there's some lag time in there, and so I'm not surprised that some of these people are deciding, well, I think I'm just going to check out here. Some people don't want to be a burden.
That's right.
Yeah.
And along the same line, if a person really has decided to commit suicide, you know that because they're talking to you about feeling hopeless. So just remember, that's the key word. If they start feeling there's no hope, most people then tell you, it's okay now. I know people are afraid to ask, well, when you say there's no hope, do you have a plan? It's okay to ask them. Do you have a plan of how you're going to hurt yourself or harm yourself? And I think it's very candid of Dr. Harding to talk about the fact that no matter what the psychiatrist may do at the time of the interview, if this person is convinced that they have a plan, that they're going to take a gun and they're going to shoot themselves or jump off the poly, there's nothing that you can really do to change that person. But there are things that you can do to try to identify if they have a plan or they're going to, and also if they've had any history of trying to hurt themselves in the past, whether that's with a drug overdose or cutting themselves.
It's important that we really pay attention to the words that we use in these situations. I've heard doctors give a diagnosis and simply say, well, there's no hope. See you next week.
Yeah.
That's kind of, really not good news. But it's also really important that as caregivers, we pay attention to the words that we use and that we understand their perspective, that we don't say things like, it's okay if it doesn't change. It's not okay to that person. So we have to really think very cautiously how we respond to our care receivers.
Just so you know, just for the record, that's something I never do. I never tell people there's no hope, because when you're given this kind of information, quite often if it's a mixed dementia, if it's a vascular dementia, that doesn't mean it's going to progress. There's things you can do. I try to give people hope, even if it is straight out Alzheimer's. I tell them, hey, there's some medication we can get you on. There's things that we can do, because, it's, how many of you, if you even thought that you were going to have Alzheimer's, that's pretty much a death sentence, and it's just it's something that it's really hard to deal with and wrap your mind around, and you're just not sure how you're going to respond to that. So I'm very cognizant of someone's thoughts. I usually spend, Dr. Fernandez, she's very busy. She doesn't have but maybe 12, 15 minutes. But when I'm sitting down with people, I'm going over test results. I'm sitting there for at least 45 minutes explaining things, test results to the family, to the patient. Make sure they understand what this means and where to go forward and how to go forward is very important.
I would like to plead to the Mental Health America of Hawaii to take up this issue. It's a policy issue, and state organizations to see if we can somehow modify or change the law regarding imminent harm, so that people are not sent home from the emergency room.
We're actually working on that.
Thank you so much. Thank you.
Yes. And I just wanted to echo something Sarah said. Don't ever be afraid to ask somebody if they're feeling suicidal. And we're talking about any age range. And I think many of us think, well, if we ask them, then that'll plant the thought in their mind. Well, that's not true. And it's just so important, because if you don't ask, you won't know, and then you won't be able to help. And there's always help. Every person who's suicidal secretly does not want to kill themselves. They want to figure out a way not to kill themselves. So I'd like to open up to the audience for questions, and please say your questions slowly and loudly, and then I'll repeat them, because I think you noticed this is being taped on Alelo. So yes.
For the panel, do you have any advice for caregivers who have family members or clients who are up frequently during the night with behavioral issues?
So the question is, do you have any advice for caregivers who have clients or family members who are up during the night because of behavioral issues?
Yeah, what type of issues?
Say somebody who just sits on the edge of the bed and doesn't want to lay down, but they're falling asleep at the edge of their bed.
So somebody is at the edge of the bed and doesn't want to go to sleep but keeps falling asleep.
Right, but they're in a posture where they could fall. So
And-
the caregiver, the daughter, can't go to sleep because of the guilt or the fear of the person falling.
So the person is at the edge of the bed and you're afraid that they're going to fall. So you can't sleep.
There are things that you can do protective-wise, but one of the best things you can do is to try to engage that senior in physical activity as much as possible during the day, so that at night they are actually physically exhausted.
You're probably exhausted. The other thing you can do is, okay, when you're working with people that have cognitive problems, or the dementia, we have to all begin to realize that you're not going to reason with this person. Don't try logic. So look at what's going on in the environment. What can you change in this person's environment? So one thing might be, because you need to get your sleep too, is could you put this person on a lower bed? They have the child beds or teen beds. We've done it where we've put actually futons, that kind of thing. I don't think the railing's going to work, because you'll have a person that gets hurt. Though this person probably will climb over the railings if they really, want to get out of bed. But then to try to assess, why is it that person wants to sit at the edge of the bed? They're afraid of something happening. So there are interventions, but I think from what you're describing, I would look probably at changing the environment. What do you think, Dr. Rita Bell? I keep putting her on the spot.
Yes, environment is a big issue. Thank you for raising that. You want to prevent them from injuring themselves and getting hurt. And if you have a hospital bed, don't put the rails up, because then they'll try to jump over the rails. It may be safer for them to be on a mat on the ground. Keeping the person busy in the day is an excellent idea, because often they're awake at night because they're sleeping during the day. So you could have them at a day health, a daycare, exercise, something to keep them busy. And if different things that you've tried doesn't work, it may be time to speak with the doctor regarding some medication to help them at night to sleep better.
Any other questions? Yes, second row.
There's a survey, maybe one we can mention.
A survey? So the Executive Office on Aging has a survey on caregivers for people with memory loss. So
Let
if
me
there's
add to what
anybody here-
Jody Michon is saying. So Jody's with the Executive Office on Aging, and she's actually chair of what they call the Caregivers Task Force. So for the people in the audience, it's really critical that she gets your feedback and input, because they're looking to come up with a strategic plan for the state of Hawaii that's going to address the needs of family caregivers.
Yes, back there? You.
Is there any type of medication or supplement that would help prevent Alzheimer's and dementia?
The question is there any kind of medication or supplement that could help prevent Alzheimer's?
They already have Alzheimer's? Yeah, that just slows it down. So if you've already if you're already at the level of impairment, the brain has a point of no return. If you would have to catch this like at senior moment level, the SCI level, but once you've reached early stage dementia, you've lost too many brain cells and too many connections between the brain cells, and there is nothing that's going to reverse that if it is Alzheimer's. So what can you do now? Okay, let's say you're probably a baby boomer, yeah? There's things you can do right now to protect yourself from having Alzheimer's or dementia later in life. And one of the best things you can do is some exercise. Walk around the block at the end of the day. Supplements, our food supply stinks. There's so much processed food out there with hormones pumped into it. It's not the same thing our parents ate earlier. So I take a multivitamin just to make sure I get things in me, antioxidants. I take omega-3 for my brain and things. But if you've already become demented, you can take all the fish oil you want. It's not going to help. Okay, there's nothing out there that's been proven once you've reached that point of no return.
A question?
How do you determine when a person is in that place where he can no longer be self-determining versus he doesn't have the capacity to make better decisions?
Okay, are we talking
let me just repeat the question.
Sure.
The question is, how do you determine when a person is moving into a place where they don't have the capacity to make decisions about their care?
Okay, so we're talking about capacity, like a legal matter, a financial matter, or a medical matter. Like, I don't want to take that pill, Or, okay, that's one I have. I do that on a regular basis. I'm the person, I tell you, patients really don't like me because I'm the guy that says, look, you can't drive anymore. I've got test results, you're impaired. I almost got hit last week because the guy, he didn't want to stop driving. So if you score really bad on some executive function tasks that show that you just can't, your planning, your reason, your problem solving are not good. So I've got evidence there, but I also like to look at a functional type of test, like let's say capacity issues for financial capacity. I want to know, can you still balance a checkbook? So a functional assessment is needed as well. If you're trying to get power of attorney or some type of guardianship in place, you're going to need some evidence, especially if you're going to go to court. You want to have some solid evidence that shows impairment. Okay.
Any other questions? Yeah, back there. You know what? I'm sorry, I can't hear you.
Could you repeat that?
Mm-hmm. Okay. So the question is, how do you get a person with Alzheimer's, maybe early stage Alzheimer's, to go out of the house?
It's a real issue. They like to sit and watch TV. He doesn't want to leave. No, he's not doing that. He just sits there all day long, won't go outside, no friends. Yeah. It's a tough one. I mean, because they're losing their initiative to go out and do the things they used to do. They start losing interest in their old hobbies. You might want to check to make sure it's not a hearing issue. I know some folks that are losing their hearing, and so they start isolating from their friends. They don't partake in conversations anymore. Sometimes it's as simple as changing the battery. Other times, of course, it's much more difficult. You guys have any?
You might try using the tactic I've seen some folks use is ask for his help. Say you need him to go help you do something. And you're going to have to make up things. But sometimes that's a way that you can get somebody where they don't want to go out, but since you really need my help, okay. And once you get them out of the house, don't come back too soon.
You mentioned that he would be willing to go out of the house, leave the house to visit his sister. That's the only thing. So, well, when he agrees, you can tell him you're going out to visit the sister and then take him on a little longer ride to wherever you need to take him, whether it is church, to an exercise place, and then go to sisters.
That's a
That
great
might
idea.
work.
You got a question over here?
Yes, I'm 81 years old, and I'm trying to not get dementia all the time. I understand that being active physically and mentally is very important, and eating properly. And I was told I went back to drinking coffee, walnuts, blueberries, broccoli, and dark chocolate.
So you were saying,
What else I need to do to take care of my brain? Dr. Carter.
okay, so the question is, you're an 81-year-old woman who wants to keep her physical and mental health good and not have dementia, and so you've been told to eat walnuts and blueberries and dark chocolate, broccoli, and drink coffee. So is it
First
any-
of all, congratulations to you for being so proactive. I mean, that's excellent. If you could convince two friends of yours to do the same thing. Okay. So are you doing any physical activity? Are you doing any walking?
Oh, yes, I walk 3 days a week. I teach Tai Chi. I'm from Long Beach, California. I'm visiting.
Okay.
My center has Tai Chi, which is for arthritis. And
Okay.
I teach exercise, weight.
Don't worry about it.
You're doing fantastic. Are you doing any brain stimulation? Are you-
I think being here is one brain stimulator, like going to these conferences.
Yeah, social, being social is very helpful. The only thing that I can think of throwing on top of what you're doing is just adding some brain stimulation. If you're doing crosswords, if you're doing something to actively stimulate your brain. Okay, are you doing brain games on the computer? I tell you what,
brain
go to my
games.
website and play the brain game Ace to King. It's with cards. Anyone can go up there and learn how to play it. It's good visual, memory, and attention stimulation. BeDementiaFree.com.
So we need to wrap it up. I'd like to thank our panelists. They've been incredible, so thank you very much. I'd like to thank some of the people who helped make today possible. Several of our board members. Have you heard of a hands-on board? Well, that's what we have. Mary Pat Waterhouse, our board president, Gina Derleland and Sandra Sims have both helped out today doing everything that needs to be done. And I'd also like to thank Jerry Medeiros, who is our new operations manager, who spent the last 3 weeks getting this event put together. And I'd like to remind you there's an evaluation form. Please fill it out. We want to know what you thought of today, what could have been better, and what subjects you'd like us to cover in the future. So thank you for coming on behalf of Mental Health America of Hawaii.